Is that cutting out or is that? So I'm a palliative care doctor. I'm working in a hospice down in London, although I grew up in Norwich. It's very much, I still consider it my hometown, so it's great to be back here talking about something that is so close to my heart. So I've been a palliative care doctor for some time, and I've been working in this field that is now known as compassionate communities for about 15 years. I'll talk about how the movement has really evolved during that time and why I think now is the time for this movement, what relevance it has for us today. So I'm going to spend the next half an hour talking about really what the compassionate communities movement is. So where did it start, what are the principles that underlie it, and why it's important. Then I'm going to talk about what impact they have, and that's really what my PhD has been drilling down into, understanding what relevance these approaches have and what impact they can have to address in part some of the demographic changes and the other changes that Louise was mentioning. And then finally, in line with the theme of today and the theme of Dying Matters Week, what can you do, what relevance does this have for ourselves both as individuals, members of communities, but also as professionals. And so I think it's important to remember we all have a role to play in this as people, but also as professionals. So those are what things I'm going to cover over the next half an hour. So the challenges, Louise has really given a great overview and description of what the challenges that we're facing are. I'm not going to go, obviously, to repeat the demographic changes. They are really significant, and particularly within end-of-life care, there are increasing numbers of deaths years on year, and that is a real challenge that we are going to have to manage because it's coming now, it's the reality. There's also new public health threats, so loneliness and social isolation is a really big topic at the moment, and it is moving into people's kind of consciousness. People are understanding this as real movement, and I'll look at a paper that really, I think, really clearly explains what relevance and what impact this has for our practice. We're looking more broadly now, so health is not just this kind of absence of disease. Increasingly people are looking at this more holistic definition of health, so it's about well-being, it's about being able to live your life, cope with threats, resilience, and a community's capacity to help. So within that kind of broader definition of well-being and resilience, the social determinants of health are being increasingly recognised. There's been commissions on the social determinants of health for the past 30 years, but I'd say it's only over the past, say, 5 years where people are really waking up to the fact that how and where and in what way people live have profound impacts on their health. And unless we begin tackling the social determinants of health, the kind of biomedical model of health can only do so much. It's kind of tinkering at the edges. The real changes are how and where people live, and they're the social determinants. And the issue with looking at social determinants is that they're not really amenable to change in A&E in a crisis on a Friday night. They have to have upstream determinants. You have to start looking much, much earlier to how we can change them, because they're not quick fixes. So that obviously links with their funding pressures, because they're often quite cheap to start looking at when you're looking at a kind of public health intervention. But they can save money. And there's a lot of studies looking at kind of the role prevention and upstream interventions can play, and funding pressures they can relieve. So there's a lot of interest, both because they resonate and they're appropriate for improving health, but they can improve, they can support cost reductions. And unfortunately, compassion in care is being questioned. The Francis report, mid-stats, etc. We're at a time where compassion is being questioned in the care. So all of these challenges or opportunities are pushing to kind of this idea of building an impetus for change. So really, people are saying the existing models of which we have been working, the NHS being designed, this kind of acute care model is just not going to be fit for the future. It's not going to equip us to deal with the needs that we're being faced with. So new models are needed, and that's accepted. But where people are looking now, what I'm going to talk over the next few minutes about is what are those new models? How do they differ from what we know now, and how do they differ from the kind of institutional acute care kind of models? And they involve communities. That is the key. They involve citizens, communities. They don't really look at patients and their nearest and dearest. They look at communities. and as people, as individuals. So there's been a series of reports, and I think Richard spoke about the zeitgeist changing, and I think that would be really true. So the change is happening, and all of these reports have come out over the past 5 to 7 years. So the Marmot report, Healthy Society, Fair Society, Healthy Lives, it basically says if you don't live in a fair society, you can't become healthy. The impacts of social determinants are so significant. NICE guidance now on community engagement, so there's a real understanding that engaging communities in their own solutions changes health outcomes. There's been a slew of documents from the Department of Health, the government, talking around social action and how that changes wellbeing. This is the NHS Alliance. They brought out their Charter for Community Development in end-of-life care. This is an essential thing that all NHS organisations should look at. Nesta, this was recently the power of people-powered movement. So this is saying health should be a social movement. It's more than just the professionals, the institutions. It's beyond that. And then of relevance for us, the Ambitions Framework, a year and a half ago released. And Ambition 6 says each community is prepared to help. And that is really the kind of the commitment to this approach, running alongside 24-hour access, sufficient workforce, etc. So all of these kind of show there's a general acceptance that actually there's something in this and we need to promote it. But not moving on from just reports, because these are helpful, there's now a really building and strong, rigorous evidence base. I'm doing a PhD, I like knowing about the evidence for it, and this report that came out, this meta-analysis that came out in 2010, I think is one of the single most important and exciting studies to have been published in the past 10 years, and I think it could really redefine how we work. So it's called Social Relationships and Mortality Risk, not a particularly catchy title. This is free to download from the PLOS Online, the journal site, so it's open access. But basically the authors wanted to say, we know that there is anecdotally and a few studies showing that if people don't have a good, strong social network, they're likely to do less well. And there are loads of different studies picking up different angles of this, and they said that we know there's something in this. So they wanted to really answer the question definitively. They did a meta-analysis, and they wanted to say, to what extent do social relationships influence mortality, basically? So they did a meta-analysis, which is where you pull together all the different studies. So they had data for over 300,000 people, so an enormous study. And they found some absolutely stunning results, which were that if you have a good social network, you have a 50% increased likelihood of surviving. So that's really significant. And the stronger your social network, so there's a dose-response relationship. So the stronger your social network, the more likely you are to survive for longer. If you just have a weak social network, it confers a small increase, but the stronger your relationship, the more likely you are to live for longer. So these results were compelling by themselves. But then they produced this graph, which, so if we start at the bottom, basically this is all your increased likelihood of survival. So point 1 is a 10% increased likelihood, 20% goes up. So at the bottom there's air pollution, topical at the moment, and so moving air pollution from high to low gives about 10% increased likelihood of survival. Underdoing cardiac rehabilitation, if you've got congestive heart disease, that confers about 20%. Not drinking or drinking 6 alcoholic drinks a day obviously confers a survival benefit. Smoking 15 a day, if you stop that, confers a survival benefit. And at the top, beating all of these well-known public health impacts are social mortality, social networks and the relationship that confers to health. So this was really compelling, and I would really recommend reading particularly the conclusions of this study, because it says we cannot ignore this as public health, as healthcare professionals, and as society. And what they think that this demonstrates is in the 90s and before, there were lots of kids in orphanages and they were being cared for and fed, but they did not have that human interaction. And the mortality rates were so high for the children. Lots of studies went into it. They worked out it's around human connection. The kids had human connection, the mortality rates dropped, and the whole way that care was delivered to very vulnerable children was completely transformed on the basis of those studies. And what they say, this is the same, particularly for elder people. for the elderly, this is the same kind of serious outcome, saying we cannot ignore this, and social networks, social relationships are essential for not only quality of life, but for survival. So I think really compelling paper. So all of this evidence and this kind of movement has moved towards something called the new public health approach to end-of-life care. And it goes by many names, which can be a bit confusing: health promoting palliative care, community engagement in end-of-life care, social approaches or social networks, and compassionate communities. But all of these come up with the same meaning, that we're looking beyond professional interventions and how professionals can work with communities to change experiences. So the title, the term compassionate communities came up with Alan Kelleher, who is a public health professor, palliative care professor, and he described the alignment of these two apparently paradoxical disciplines. He said for too long, public health and palliative care has been seen as mutually exclusive. Public health kind of has death as the final thing. When all of the other campaigns have not worked, you can't change what's going to happen at the end. And he said no. There's a huge amount of harm reduction, early intervention you can still do if someone has a life-limiting illness and around death and dying. So he aligned these two apparently paradoxical disciplines. And he says that compassionate communities are community development initiatives that actively involve citizens, and that is the crucial word. This is not about patients, about carers, about loved ones. This is about people as individuals in their community, that both people who are unwell and people who are not. And it's about partnerships. It's not about replacing professional services. We will always need high quality services, controlling symptoms and pain at the end of life. But as Louise said, there's just never going to be enough professionals to be there at every single person's bedside. And in many ways, it's not appropriate for professionals to be there, but people who you know better and who are closer to you and more appropriate to meet your social needs could be there. So he's saying that the partnerships need to exist. The new public health, the principles are, it recognises the social character of illness and dying. It's person in community rather than person in family, and I think in palliative care we are brilliant at person in family. We do holistic care, and that's how the specialty has really been defined. But this goes beyond this. We need to look beyond the people who are on our books and their carers, beyond the people on our doorsteps, to the broader community with which we're serving. Projects like this, new public health approaches, cannot be built within a clinical framework. They have to sit within a new public health or a community development framework. And that is difficult because hospices, certainly where I was working, is quite risk averse. It's monitored by CQC, you have the board of trustees have requirements, you have regulations. So it was about a kind of compromise. All of the compassionate neighbours had a DBS check and they had references. They also had a very long training programme, which was part to build a really strong network of the neighbours themselves, but also so that the people doing the matching really knew them. And actually we had a lot of very vulnerable and quite elderly people coming in to be compassionate neighbours, which was brilliant. We wanted this to be very different from the kind of classic demographic that was often in hospice volunteering. But it meant that some people weren't able to get out there and doing volunteering themselves and couldn't get out visiting. So we know them very well and help people be matched, say, to do some telephone calls, supporting, or other kind of ways. So it was saying, this isn't just about you going and doing that matching. This is about you as a person, developing your own understanding about your own end of life, learning skills, maybe going and being matched with a person, but if not, actually being part of the training acts as an intervention in itself. And that's what we found, that we had a really wide inclusion for people doing the training, and not everyone either wanted to or was able to carry on and then be matched up. But that was fine. The hospice initially was saying, why is not everyone, what's wrong with the training? Why is not everyone progressing to be volunteers? But we were saying, the key thing is that people through the training have reflected on their own mortality, their own wishes, advanced care planning, etc. And they take those skills out into the community. So it's a standalone intervention. And then if people carry on being matched and go, then that's another aspect of the training program, which is great. So it's a really completely different model. It caused quite a lot of conflict, as you can imagine, within the hospice, and we had a lot of negotiation around risk. But what this really sets out is a public health, a population approach. So you're not here, when you're doing this work, you're not thinking about who are the patients in our beds or in our community services. This is about a population approach. We're having a wide inclusion, getting everyone into the hospice who would not normally come here, teaching them about end of life, developing their skills, giving them confidence, and sending them out. And we may never see them again. And that's hard, particularly with the funders we had, to account for what that change was. But we were saying that that's the point of a community development initiative. You're giving a community skills and then going out and seeing how it manifests. So then there's three kind of key outputs, kind of facilitators that I'll go through now. The first is that relationships are mutual and reciprocal. And that was what was so different about the relationships that we saw, people being matched up. Those receiving the care were not passive. They were active in that relationship, and the training supported people to say, you're all peers, you're all out there, you just happen to have done the training, but actually this is a mutually supportive relationship. And where we saw the biggest impact was where the person at their own home was just as active in supporting that person who was visiting them as the person visiting. So the fact that they were both engaged, caring for each other, and saying actually we're all on a different point of life's journey, someone happens to have more needs here at the moment, but actually it's a mutually supportive relationship. And that's where we saw the impacts happen, when people could realise that kind of relationship. Secondly, people are desperate to do this. And so my research showed that people said, hey, we already do this, I'm caring for people on my road, they said, I do their shopping, I'm already doing this. Great. And that was great, people could continue doing that. Another large cohort of people said, I desperately want to do this, but I'm frightened. I don't know how to just knock on someone's door. They don't know me. You know, what happens if I do something wrong? What happens if they slip? Or, you know, will I get in trouble? And I was not expecting this finding from my PhD. And that kind of differs from all the work internationally and in Kerala. Because I think we have quite a risk-averse culture, people are quite frightened, and there's a kind of people don't know each other often in many areas on the street as they would have done, say, years ago. So there's a role for the kind of legitimisation, saying it's okay to go out and care for your neighbour, and we will give you that kind of confidence and legitimacy to go. And this is where a really important role for palliative care services comes in, because hospices and other services have a role in saying, let's give you that legitimacy. It may be an ID badge with a lanyard. It may just be the confidence to have done training, to say, actually, I know what to do. If someone falls over, I'll be okay. So we looked at how we could give that legitimacy, but without professionalising. So it's still around using your own common sense. There weren't endless flow diagrams in training books. It was around, well, if someone falls over, what would you do normally? Let's think through that. And it was always the backup of the hospice, but it was around supporting people just to be more confident versions of themselves, rather than a new role in a hospice doing new volunteer. Because actually, we want to support this in a really sustainable way. And the final one was, this is not another service, and that's why it's not created within a clinical service. This is around a social movement. It's a changing around how people view themselves in their community, the responsibilities they feel they have on their road as a person and then also as a professional. So it's really saying it's a hybrid between the two. You know, it starts off being supported by a hospice, but the idea is it will become a social movement, and it's not bound by the same restrictive things that a service is bound by. And then I'm going to talk about just 3 impacts. So the first, this changes well-being for people, but it really changes well-being mainly, my results showed, for the compassionate neighbours. And that's because they were the ones being active, they had agency, they were going out and changing other people's experiences and coming back and saying, wow, I did that, I'm now an active member. And this is really the upstream example, because these people have now got this kind of confidence and legitimacy, and they were thinking, you know what, I'm going to change other things on my road. I'm going to start looking at why, certainly we had a big estate, and there were lots of people who never came out of their rooms. One was being visited, and people were saying, well, we're going to go and have a look at why no one else is visiting the other people who we know are behind those doors, but we can't get there. So they were beginning to look at how management within the estate could change. So they kind of had agency, and that is what changes to well-being, is people feel confident. So this is a real example of an upstream intervention, with the compassionate neighbours being the focus of that intervention. And for the hospice, there was a big change in community attitude. So people who would never have normally come into the hospice, who would never have normally thought about any form of advanced care planning or issues about whether they'd like to die, were suddenly coming into the hospice, having those discussions. And we saw people coming in to be inpatients who would never have normally come in. So there's a change kind of more broadly from the hospice's perspective, that this is a way of getting changing attitudes in a way that leaflets and other things, you can't get that change, because peers from those communities were going out saying, it's okay in there, I'm a compassionate neighbour, they're doing great stuff, come and have a look. And that was how we were noticing a real change in community attitude.